I'm going to focus on strategies to help you think your way through the answers to what you might see in gastroenterology. The question type that you'll see is called the clinical vignette. The vast majority of the questions that you're going to see are going to give you a patient that has an age, a gender, maybe an ethnicity, and then symptoms. They will give you physical findings and laboratory data and then ask you a question that usually falls in one of these four domains: preventive medicine or health and health maintenance, the mechanism of disease or pathophysiology, and the two big categories for internists are how do you establish a diagnosis and what treatment is appropriate. We'll begin with the esophagus. The esophagus has two major functions. It transports food and it prevents reflux of contents from the stomach back into the esophagus. Why is that necessary and how can we remember it? If we understand normal esophageal motility, we'll understand how the esophagus does both. The esophagus is this muscular tube that extends through the negative pressured chest and courses into the positive pressured abdomen. So it must transport food against a pressure gradient. The only way it can do that is with active muscular contraction called peristalsis. And then, since the abdomen has the higher pressure, the contents in this tubular structure could reflux back up. But we have the lower esophageal sphincter to prevent that. So the two functions are to transport food and to prevent reflux. Normal esophageal motility, we use a manometer that has pressure transducers at 5 centimeter intervals. And don't let this scare you, but normal esophageal motility, the blue line indicates a swallow. Within a half a second of a swallow, the upper esophageal sphincter or cricopharyngeus muscle relaxes. A wave of peristalsis is triggered up in the pharynx, and the food bolus, we can see peristalsis as staggering of these peaks of contraction that extends down the esophagus. The other very important function is the lower esophageal sphincter. After the swallow, within 2 seconds that sphincter will relax. It will remain relaxed until the wave of peristalsis passes through it, and then it will contract again at its tonically resting state to prevent reflux. So we have transport, prevention of reflux. Now, everything that I'm going to say is in your textbook chapter. And so the best strategy might be to just make some peripheral notes about what you might want to read or review again. The first symptom that the esophagus can cause is dysphagia, which is difficulty swallowing, the subjective awareness of difficulty swallowing. There are two major causes of difficulty swallowing. Mechanical dysphagia caused by a narrowing of the lumen, or functional dysphagia caused by inability of the muscles of the esophagus to propel the food against the pressure gradient. The history of a mechanical narrowing is that the dysphagia is usually gradual, but there are some things that can give us sudden. The history is progressive. First meat stick, then bread stick, then liquid stick. Whereas in a motility disorder, liquids and solids stick at the same time. Solids are usually the type of food that gets stuck in a mechanical narrowing, again, solid and liquids in a motility disorder. There's been some discussion about temperature sensitivity in that motility disorders, either hot or cold foods can stimulate that, but there's very soft evidence to confirm that. But the response of the food bolus, if we have to regurgitate it, that's usually a mechanical narrowing. If drinking water causes it to pass, that's suggestive of a motility disorder, because the pressure of the column of liquid that we drink will overcome the pressure of resistance of and flush the food through the esophagus. If we know the type of food that sticks, the course of dysphagia, whether it is intermittent or progressive, and whether or not there is heartburn, 3 questions, we can virtually make the diagnosis by history alone. And so this is a great symptom complex to ask questions that are based on the history that they give you. Let's look at some examples. First, progressive dysphagia. First meats, then breads, then liquids. That suggests a mechanical obstruction, although chronic motility disorders, people who live with chronic disorders, the symptoms can blur sometime, and their ability to differentiate things gets blurred. So progressive dysphagia, usually a mechanical, but it can be a chronic motility disorder. So if they give you a person, any age, that has progressive dysphagia, and they give you this X-ray, we notice that there's a narrowing of the lumen in the distal esophagus. We also see that there's rugal folds which are only present, rugae are only present in the stomach, but we see one extending into this distal little pouch. That's a diaphragmatic hernia. A stricture in the distal esophagus is almost always peptic esophagitis due to chronic reflux esophagitis. Let's look at a variation on this theme, though. If we were to have a narrowing in the mid-esophagus, see the tubular esophagus coming up? Then we have a narrowing, and you may have an ulcer there as well. This X-ray, a narrowing and an ulcer in the mid-esophagus, is a Barrett's esophagus. Barrett's esophagus is metaplasia of the esophageal epithelium from squamous to columnar.